Okay? Pain sensation to reach the cortex from the nociceptor, it requires 3 neurons, right? It's only primary, secondary, tertiary. Primary is sensory receptor. Secondary, it's synapses at the level of the cerebral ganglion. Then decussate, and contralaterally ascends to the thalamus. From the thalamus, they synapses with third order neuron. Okay? You still remember? Okay. So to develop pain, that we must have stimulus, either the external stimulus or enteral stimulus. From the internal or external also can be. Pain occurs whenever tissue are damaged. For internally, whenever we have tissue damage, okay, it will develop as a pain because we have the stimulator. When tissue damage, a lot of mediator, toxin, inflammatory mediator will release. That stimulates to the pain nerve ending. Okay, it develops pain. So pain has been classified into the two major types: fast pain and slow pain. Okay, fast pain, immediate pain, and slow pain. Can you give example of the fast pain and slow pain? Leader break. Okay, how about the temperature? You apply the hot. Fast pain, right? That one is like speedy pain or fast pain. How about the example of slow pain? Which one? Headache also can be slow pain. Internal organ pain. Internal organ pain is slow pain. It's like colicky pain, gallbladder pain. Have you, maybe any one of you has sensation of dysuria and dysmenorrhea? Okay, dysmenorrhea also is some kind of the slow pain. Chronic pain, slowly and feeling pain. Okay, that are example of chronic pain. And some kind of the gastritic, stomach pain, right? Stomach pain, very slow pain. When you press with a pillow, then feeling like you will lift the pain, right? Slow pain, okay? Or we can say the dull aching pain for that one. Slow pain begin, okay, first pain sensation you will have 0.1 second after pain is stimulated, and slow pain after 1 second, okay? More than that also. So rate of tissue damage also can be the stimulus for pain. Okay. For example, like temperature. When temperature becomes above 45 degrees Celsius, thermoreceptor will convert it into the pain receptor. Because some thermoreceptor, if so firing, it will be pretending or behaving like the pain receptor. Okay. 45 degree above, the people will get the feeling of pain. And then below 5 degree of temperature also feeling pain. Okay. Tissue ischemia as the causes of pain. Okay. Any reason of tissue ischemia, no blood supply, then it will causes accumulation of the substance P or some kind of the inflammatory mediator or some kind of mediators. Okay. And lateral accumulation also causes pain sensation. Okay, special importance of chemical pain during the tissue damage is because of release of this chemical mediator, bradykinin, potassium ion concentration, bradykinin, especially bradykinin, and another one we have substance P. Okay, so they are the pain stimulator. Okay, that stimulate to the pain nerve ending, C nerve fiber, and we feel pain. And potassium ion concentration and proteolytic enzyme. Okay, so they can stimulate as a pain nerve fiber, then we feel pain sensation. Okay. So pain receptors are free nerve ending. Our superficial tissue has a lot of pain nerve ending, nerve fibers compared to deep tissue. Deep tissue, you feel the stomach pain or gallbladder pain, something like that. But you just feel pain only that it reached to the epithelial surface area or it reached to the area that a lot of nerve supply occur. Inside that, why we cannot feel too much pain? Okay, some area because of we don't have pain receptor, nociceptor in the internal organ. Okay, not like superficial. Superficial we have a lot of nociceptor. And non-adaptive nature of pain receptor. Remember that we can classify receptor according to the adaptation, right? So this pain receptor is the highest slow adaptive receptor. As long as there is stimulation, we still feel pain. Okay. three types of stimuli that excite pain receptor, non-receptor, like mechanical, thermal, and chemical. Mechanical stimulus, any kind of mechanical, okay, that injury or whatever mechanical stimulus. Temperature and chemical, any chemical like just now inflammatory mediators or the potassium ion concentration and H plus. So these are the main stimuli for creating the pain. Okay. So as you learned this morning that and spinothalamic thread, okay. So one is for vibration proprioception and fine touch. Another one is for pain, temperature, and crude touch. Crude touch is mainly related to anterior spinothalamic thread. Temperature and pain is mostly related to lateral spinothalamic thread. Okay. Okay. So then this thread will go to integrating center. Okay, what is the integrating center for sensory? This morning you learned about the somatosensory cortex. Cerebral cortex, which area? Cerebral cortex, somatosensory area, which area? We have primary area and association area, right? S1 and S2. Primary area mainly and associated area. Okay? So now we go back to the lateral spinothalamic thread that carry pain and temperature sensation. Okay? So exactly like similar, same pathway that morning you learn. Okay? But this afternoon what you need to learn additional is for pain that we have lateral spinothalamic thread. That lateral spinothalamic thread is formed by two pathways. One is carrying slow pain nerve fiber, another one is for fast pain fiber. Okay, because its lateral spinothalamic thread is composed of something like A delta fiber and C fiber. Okay, if pain stimulus is the mechanical stimulus or stimulus sharp pain, or maybe you apply to the cutaneous area, that form as a fast pain, right? Why fast pain? Because of this is carried by A delta nerve fiber. Okay, that A delta nerve fiber, that thread we call neospinothalamic thread. Okay, neospinothalamic thread. If slow pain that coming from the internal organ, that is carried by paleo-spinothalamic thread. Okay, why slow pain? Because of it is carried by C fiber. Okay, C fiber and myelinated fiber. Okay. Here you can see in the diagram. Okay, so you give pain stimulus. If the pain stimulus is the mechanical pressure or any sharp pain, okay, that is sensed by nociceptor, the green one. Look at green one. Nociceptor, okay. Then synapse with second order neuron. This is first order neuron. Receptor becoming first order neuron. Synapse is second order neuron. Okay, decazade, and then ascend control laterally. So this third order neuron will second order neuron synapse with third order neuron at the thalamus. Okay, BPL nucleus. Then it will give projection to this area, to the cerebral cortex. Okay. Can you see that is the green pathway give rise projection at the lower level? At the midbrain level. Green one, green pathway. The green pathway give projection to hypothalamus. No, right? Okay, this one is very important. Okay, so next you see, you give stimulus or maybe internal organ stimulus. You have pain like stomach pain. Okay, it's carried by receptor. We have nociceptor. Okay, even though that we have less number of nociceptor, that still can feel. Okay. That is carried by N myelinated fiber, C fiber, first order neuron, synapse second order neuron. Then decazade, controlaterally ascend. Okay, so this one synapse with third order neuron give projection to the cerebral cortex mainly. But before reaching to the cerebral cortex, which area they give rise to the branches? See, what is this one? A lot of station they rest. See. Reticular formation area. Next is periaqueductal gray matter, this nucleus and hypothalamus. Okay, so we have reason that some slow pain, whenever we suffer slow pain, that the patient will get vomiting, okay, dizziness, and sometimes fainting attack, right? Because of pain, colicky pain. they got fainting attack, a lot of sweating. That is because of this projection is going to the hypothalamus. Okay, what control center we have in the hypothalamus? What center we have? Hypothalamus, autonomic nervous system. Integrating center is at the hypothalamus, right? Hypothalamus, when it's go to the hypothalamus giving branches, whenever we have pain, because of that branches activate with the autonomic nervous system. Okay, especially if let's say like parasympathetic nervous system, it will causes a lot of salivation, or maybe like if too severe pain also can get fainting attack. Okay, people can pass out. Okay, sweating, vomiting like that. Okay, that's why we cannot sleep at night if we have that kind of chronic pain. You see, one of the projection, okay, branches will go to reticular nucleus, right? What is the role of reticular nucleus? Activating arousal function, right? This is awake. So that's why whenever that area is stimulated, okay, because of pain nerve fiber, the people cannot sleep. Okay, because of that reason that we have additional symptoms apart from the pain sensation. Okay, so this one you read later. Everything say only that you have to learn about type of nerve fiber that carry slow pain and fast pain. Okay. Okay. Now very detailed, I'm going to talk about this lateral spinothalamic tract, paleo-spinothalamic tract that carry slow pain, neo-spinothalamic tract that carry fast pain. This neo-spinothalamic tract fast pain is carried by L delta, okay, high myelinated nerve fiber, okay, still have myelin. And paleo-spinothalamic tract that carries slow pain sensation is carried by C nerve fiber. Okay, C nerve fiber. That's all you need to know. The rest is everything same like what you learned in the morning and just now. Okay, same thing. First order neuron. Okay, that is receptor, nociceptor. Then synapse with second order neuron at the dorsal root ganglion. Decazet, ascent contralaterally. Okay, then synapse with third order neuron at the thalamus level. But here what you have to add in on is, if let's say like the question is sharp pain or fast pain. Okay, so then you can say that this type of pain is carried by which tract, paleo or neo-spinothalamic tract. If you are not sure, we just explain adding both. So paleo-spinothalamic tract carries slow pain, neo carry fast pain like that. For example, like meningeal irritation will be what type of pain? Meningitis, meningeal irritation. Slow pain, right? Whatever internal organ or epithelial tissue, it will be slow pain. Okay, slow pain. It can be slow pain. Okay. So we have that lateral spinothalamic tract because of the made by the A delta and C fiber. We say that dual pathway for transmission of pain signal to the central nervous system. Okay, so one is L delta fiber. They have high velocity since nerve fiber is higher, but not highest one. Okay, so they carry first type of pain and slow pain carried by C fiber. Their velocity, speed of velocity is lesser than this L delta fiber. Okay, so here you can see that this lateral spinothalamic tract, okay, you can see this is lateral spinothalamic tract. It's composed by both A delta fiber, okay, A delta fiber and C fiber. A delta carry fast pain, C carry slow pain. Okay. So this one first order, second order, third order, same like the previous whatever you learned. Okay. So here what is the additional point is that from the first order neuron, right? They synapse with second order neuron at the dorsal root ganglion of the spinothalamic tract or spinal cord. They release neurotransmitter. Okay. That neurotransmitter is glutamate and substance P. Glutamate and substance P. This substance P is the neurotransmitter that activate to the pain nerve ending, and people suffer pain because of that one. Okay. If some medicine or maybe like morphine or protein, if we give, it can block that area or the release, inhibit release of system P, then pain sensation will be blocked. Okay. Second order neuron cross over the opposite side. Okay, ascend laterally, control laterally, and third order neuron. Okay, same. Okay. So the first sharp type of pain can be localized much more exactly in the different part. Why sharp pain that can be localized? What is the reason that you can localize? You can say that, oh, I have a pain here. What is the reason?
I see.
Because cutaneous pain, we have a lot of sensory receptor, right? You can sense. But for internal organ pain, that sometimes it's coming from another part, but you think that it's coming from here and here like that. Okay. So that we have the reason that we call the refer pain. Okay, refer pain. For example, like cardiac infarction patient or angina, but they have feel pain on the jaw or the shoulder. Okay, that is based on the theory of refer pain. Okay. So here spinothalamic thread chronic pain, right? This one okay, first order, second order. But differ from the spinothalamic thread is they give branches before entering to the thalamus and to the cerebral cortex. Okay. First they will give to where? Reticular formation area, and then to the limbic system, to the hypothalamus. So because of that reason, we keep awake whenever we have slow type of pain. Limbic system got emotional experience that people will cry, or maybe previously we had the same feeling of pain. Okay, even though pain is not severe, but in the past you suffered like more severe pain, but you will think that the pain is severe because of past experience. It goes to the limbic system. Okay, then because of projection to the hypothalamus, it will stimulate autonomic response, like just now nausea, vomiting, sweating. Okay, a lot of the autonomic response will occur. Okay, so different from the paleo and neo is paleo slow type of pain give branches to hypothalamus, limbic system, and reticular formation area. Okay, clear? Yeah. Okay, if that's the complete removal of somatic sensory area. Okay, cerebral cortex. If removed in the experimental animal, we remove cerebral cortex area or blocking that area, not suffer from pain. Can you still feel in pain? Yes or no? Because just now, if let's say like chronic pain, if like sharp pain or fast pain, yes. But if you suffer the chronic slow pain, can you still suffer the pain sensation even though you don't have cerebral cortex? Cannot. Because just now, slow pain give projection to the hypothalamus, limbic system, and the reticular formation area. You still can feel pain or not? Still can feel pain. Okay? So pain stimulus entering from the brainstem, reticular formation, thalamus, and other lower brain center causes conscious position of the pain. Okay? Still you conscious that you having pain, but you cannot interpret exactly what type of pain it is. Okay? Pain, but exactly cannot identify. Okay? So, however, it is believed that cortex play an especially special role in the interpreting of pain quality of pain, even though pain perception might be principally the function of lower center. Okay, that perception from down, okay, like hypothalamus, but interpretation quality of pain that is identified by cerebral cortex. If blocking that area, the identification or the quality of pain we cannot identify, but still we can feel pain because of branches given to these three areas. Okay, this one you can be asked in OBA. Okay, but if in terms of SCQ, if we ask this one, if let's say like type of pain is slow pain, you can mention a little bit on it. Okay. Why we have difficulty to sleep whenever we have the pain, type of severe pain, the slow pain? Because of it stimulates to the reticular formation area. Okay, This area where the slow suffering type of pain dominates and strong arousal effects on the nervous activity. Okay, that is the reason for that one. Okay, so next, neuronal transmission in the head and neck is transmitted from the upper part, like from the anterior aspect like face, mouth and teeth and eye through the cranial nerve. Okay, and then posterior aspect of head and neck through the spinal nerve. Okay, so that is carried by this nerve for the upper part. Okay, so how about headache? Can we say the headache is type of pain? So type of pain, headache also type of pain, slow type of pain. Okay, headache is carried by this type of nerve. Okay, cranial nerve and through the spinal nerve also. Okay, if you interest to read headache, then you can go read in the Gaitan book, right? Gaitan book is interesting that it's mentioned about the headache, causes of headache. Okay, so you can apply for clinically that one because a lot of people or maybe like we have suffering pain, right? Headache can be because of many causes. Even though we don't have any pathological background, still we can feel headache, right? Many reasons. It's interesting, just read. Okay. So we have other type of pain. Okay, just now slow pain and fast pain, right? Okay. Just now slow pain. Slow pain is coming from the internal organ. So that one internal organ can create like some kind of refer pain. Refer pain meaning that according to its terminology, refer. Okay, coming from somewhere, that pain is suffering in another area. Okay, like myocardial infarction pain, something happened at the heart. Okay, ischemia of the heart muscle, but feeling of pain at the jaw or maybe like from the stomach or shoulder. So the reason for refer pain is, what is the reason? Because you learn under anatomy. Done or not yet? Have same dermatoma origin. Okay, same embryonic origin. Because spinal nerve, the nerve emerging out from the same dermatoma area. Okay, I think last year one of the exam question from anatomy is refer pain. Actually, we can ask from the physiological point of view also, but anatomy say that they teach that one. Okay, refer pain. I think you can apply from the anatomy or physiology, but just apply more towards anatomical structure because they say it's their part. Okay. Open again. Okay. When the visceral pain fiber are stimulated, pain signal from conducted because in the spinal root segment, right? So somatic nerve coming from the periphery here is entering to the same segment with whatever nerve supply coming out from the heart. Okay. So later after coming out from the same embryonic origin, okay, it's going to the cerebral cortex. Okay, interpretation area. Brain thought that pain is coming from the somatic origin, not from the visceral origin, because somatic origin has a lot of the receptor, right? It's experience of pain. Brain noted that pain is coming from according to its experience. Okay, so that's why the response giving rise to both area. Okay. So these are the example of refer pain. This one also at least you need to know 6 example of refer pain along with the theory of refer pain. Then you can write the. Okay, sorry, this you cannot see.
Boleh lah. Boleh. Biarlah special. Bit house or S60. After worries lah. You are like I spend to my S60 one and only to me. Tapi peak pula sebab aku boleh main dekat Orina Pay. You my pay. Kenapa tak boleh sebut pay? You my research pay. I thought thought you are mine, but turns out you are someone else. You are my myocardial infarction. Dish, dish. Thank you for
Refape example that you must know. Okay, types of refape, and then what is the reason for refape? So just note down the very common refape. Okay, so one will give maybe like 0.5 marks for exam 1 and the reason 0.5 marks. Because I saw in the old question for this one.
Sakit je. Dia kalau yang basic-basic je, yang kalau kau tak payah kau perlu makan satu hari je.
Okay, so then difference between visceral and parietal pain. Visceral pain meaning the pain coming from the visceral organ, and parietal pain. What is parietal? Parietal pain, parietal, right? Now, so parietal pain, the important differences between the surface pain. Parietal pain meaning the surface pain, and visceral pain is that highly localized type of damage to the viscera seldom causes the severe pain. For example, like in the viscera, if we have pain, then pain sensation will be very rare. That's why that if the surgeon hold the gut, your intestine or maybe like brain also, that you cannot feel pain. Okay, because they don't have the pain receptor. When pain will suffer only that when the parietal, the upper layer will be the parietal layer will be affected, because in the parietal layer we have a lot of the nerve, nerve ending. Conversely, the stimulus causes diffuse stimulation of the pain, because nerve ending is located throughout the viscera. Okay, that pain can be severe. So this, if let's say like we have something happen at the gut, okay, so why we feel pain? Because of the infection will spread to the parietal peritoneum, okay, or maybe in the lungs also, that pleura, parietal pleura. Only that we can feel pain, okay. So this particular surface like skin are supplied with extensive pain innervation from the peripheral nerve ending. Why skin has a lot of feeling or sensitive? Because of we have numerous cutaneous receptor, okay. So pain from the parietal wall overlying the viscus is frequently sharp. Pain coming from the parietal will be sharp pain or fast pain, okay. Something happened. Why I cannot move my laptop also?
iPad.
So this is okay, this is differences between visceral and parietal pain. Visceral pain arising from the viscera or visceral layer of the serous membrane. It's carried out by C fiber. Because of it is carried out by C fiber, type of pain is slow pain, or we can say the dull aching pain, okay, slowly suffering, okay, which is carried by autonomic afferent to the dorsal root nucleus of the dorsal horn cell of spinal cord to reach to the central nervous system, okay. So sensory, especially from the visceral structure, is carried by sympathetic parasympathetic nerve. Then after that, the synapses at the dorsal root ganglion of the spinal cord, and it will carry out along the lateral spinal column. Okay. So visceral pain is poorly localized, and it is colicky type of pain, or bunny pain, or even biting pain type. Okay, colicky pain, for example, gallbladder pain, kidney pain, renal pain. If let's say like stone, renal stone, it will be some kind of colicky pain. It's like constricting pain. Okay. Parietal pain arises from the parietal layer of the serous membrane and from the from the organs are carried by both A delta and C fiber. If parietal layer, then mostly A delta fiber, but it can also be from the C afferent fiber. Okay, then reach to the dorsal horn of the spinal cord. Same, they will ascend together with the lateral spinal thalamus. Okay, so parietal pain will be well localized and it is like pricky and then sharp in nature. Okay. This one also same, overlapping that later you read, clinical presentation and then pathophysiology. Okay? Similar like whatever I say, like what is refer pain, meaning that, and parietal pain and visceral pain. Okay? So refer pain can be visceral pain as well. Okay? Cannot change the slides. Okay. So next part, if you have any questions so far about the paleo-spinothalamic thread and new spinothalamic thread, you can ask now. So I will continue the second part of today's lecture. If you want break, I will give, or if you want to continue, we'll continue. Continue. Because not many slides left, the rest will be, I think, like just simple. Continue. I think okay. Bringing will be resolved this one, no problem. So you want to continue? Okay, so any questions so far, whatever you learned about the paleo and new spinothalamic thread? No. So which ascending thread or which pain pathway carry fast pain? Fast pain or sharp pain? We have only two, right? Neo and paleo. Sharp pain, neo. Sharp, neo. Okay? Neo plus spinothalamic thread. What type of nerve fiber is that? Neo. Mainly A delta. Okay, A delta. Not only A. A alpha is for DCLM. This proprioceptor. This one A delta for neo or sharp pain. Okay, neo spinothalamic thread, sharp pain. Okay. How about slow pain, dull active pain, visceral pain? Paleo spinothalamic thread carried by which type of nerve fiber? C nerve fiber. Okay, so that is only differences. If you remember, you can answer the question that something related to the pain pathway. If pain pathway, we just answer that whatever I put in the slide. I think morning slides, lateral spinothalamic thread. It's mentioning every point, the key point detail. You just add on that A delta carried sharp pain or fast pain and C carried slow type of pain. That's all. And then that we can say that A delta, we can say that neo spinothalamic thread, and C we say that slow pain carried by the paleo spinothalamic thread. Only that, okay? The rest everything same. So next part, the pain suppression system in the brain and spinal cord. Now we have pain. How can we treat the pain? Physiologically or maybe like pharmacologically. Just think about physiologically. Now you learn about physiologically. Block? Block. How to block? Without any medication. Without any medication. Medication will come later. How to stop our pain? Any traditional way or any way that without any medication. Huh?
Die.
Rubbing?
Example.
Why? Rubbing is like rubbing to your surface area. That one also, huh? Touching.
Touching.
Which one? Just whatever you say is correct. I will explain.
Die.
Touch. Massage. Okay, correct. 3. Acupuncture. Yeah, very true.
Dead.
Without medication. No medication.
Die.
Acupuncture. Okay, correct. Massage also correct.
Die. Die.
Ice. Ice also cold pack. Warm pack also can. Okay. So that one like non-pharmacological pain separation way. Other than that, in the body that we have pain separation system. You know that we have hormones from the neuronal hormone from the nervous system. What happened? Okay. So that is we release our neuron release endorphin and encephalin. So these hormones are like they have morphine-like action. Okay, and then we have receptor, morphine-like receptor in the neurons. Whenever like we suffer pain, then that morphine-like receptor will be expressed more. That encephalin, endorphin will be released from the neuron. Okay, from the nerve ending. They combine with their receptor, and then we relieve pain. Sometimes we have stomach pain or the internal organ pain. Okay, so after some time, that it will be relieving the pain. That is not because of you sleeping. That is because of morphine-like substance released from our nerve neuron. Okay, that's why we sleep and then feeling like you relieve pain. Okay, so that is the physiological mechanism. Okay, another one. Okay, that we call the endogenous, the analgesic system. Okay, so why? Because of the brain suppress the impulses of pain signal to the nervous system by 3 major components. The periaqueductal gray matter. Because this one we also say designing pain control. Now you are learning about asani, right? Asani that carry sensory pain sensation. Okay, but from the brain endogenously they inhibit to the asani part by way of designing pathway, the motor pathway. So this designing pain control is formed by this one periaqueductal gray and periventricular area of mesencephalon and upper pons, and then the free magnetic nucleus and the nucleus reticular. Very difficult to see. Okay. Then what will happen? From that nucleus, okay, second order signal are transmitted down, because for that this designing also that we have first order, second order, third order neuron. Okay. Like Johnny and then I and like who also that extra job, that side business, just doing this. Okay, so this second order neuron here coming first order neuron. Okay, from the second order neuron, what will happen? They give inhibitory effects to the dorsal root ganglion, right? Pain. Okay, nerve fibers from the first order neuron, then they synaptic with the second order neuron at the dorsal root ganglion, right? From the ascending thread. But this descending pathway coming down, they inhibit that dorsal column, that nucleus, okay? That the second order neuron of the sensory. Okay? It will causes, they give pain inhibitory complex located in the dorsal horn of spinal cord. Again, they inhibit and they release the neurotransmitter that we call encephalon and serotonin and also endorphin. They are morphine-like substances. Okay, so because of that, we relieve pain endogenously. Okay, that we call the endogenous pain control system of our body physiologically. Okay. Next, non-pharmacologically, why we tend to wrap the skin near the pain area. Okay, like somebody got pain, especially like maybe like stomach pain, okay, you just wrap, or maybe back pain also, any pain, you just wrap. This wrapping will stimulate the touch sensation, right? Touch, okay, this touch. Touch is carried by what type of nerve fiber? Tactile morning, which type of nerve fiber? Morning you learn touch, A alpha, A beta, like large myelinated fiber. Okay, so this touch, that large myelinated fiber, okay, but you have to apply specific pain area. You have pain here, you cannot touch here, right? So no, cannot apply that theory. Okay, so this area you have pain, you just rubbing will cause it, touching will cause it stimulation of that large myelinated nerve fiber, A alpha fiber. Okay, so this A alpha fiber will inhibit just now C fiber that carry pain sensation. Okay, so by that way the pain will be inhibited while rubbing. Okay, so start from now, you can rubbing to the patient. Okay, don't give medicine. I will massage you. If let's say like you open this one like what chiropathy something chiropathy, or maybe like massage and clean it together. So this large type A fiber from the peripheral tactile receptor can depress the transmission of pain signal by suppressing just now C fiber. Okay, C fiber, lateral spinal thalamus fiber. Okay, lateral inhibition, that we call lateral inhibition, and we can say that that is gate theory of pain. By inhibiting pain gate, then pain sensation cannot cross that gate. Here you cannot move. Okay, so here you can see gate theory of pain. This one C fiber carried pain sensation. Okay, so coming here, if there is no gate we have, but gate is open, then it will reach to the sensory cortex, right? Sensory cortex. But when you apply the touch sensation, rubbing, okay, or maybe massage, it will activate this A delta fiber, A beta fiber, high myelinated fiber. So we have inhibitory neuron here. When you stimulate this A beta fiber, it will stimulate inhibitory neuron. What will happen if we stimulate inhibitory neuron? This gate will close. Then the gate will not allow to cross this pain sensation. Okay, so by that way we can inhibit pain sensation by rubbing or touching or giving massage. Okay, don't give too strong massage then. So it's the people will go on, but previously they got just some because of your massage. Then okay. Okay, next. I cannot change my slides here. Okay, next, hypnosis and pain control. Do you trust on this hypnosis and pain control? Yes. So what is the mechanism? What is the possible mechanism? Hypnosis, psychology, hypnosis and pain control. Because this one, according to the research that when the people got hypnosis theory, that hypnosis pain control, that their pain sensation is do not reach to the conscious level. It's like some kind of they reach the level of just subconscious. So meaning that they will not reach to the level of like reticular area, hypothalamus area, limbic system, and also exactly not reach to the cortical area. Okay, by giving the hypnosis pain control. Okay, in the past they used that hypnosis pain control. Even for surgery, they say that they use that one for a long time ago. I don't know how many years ago. Okay. Next is, what is VR? Virtual reality of pain control. You have VR, right? VR must be like something device, right? So in some country, like very few country, for example, like one hospital from Australia, they use that VR machine, okay, to treat the pain control, especially in the children. And then some people they have the severe angina patient, okay, so they use virtual reality to control pain, okay. So what will be the possible mechanism to reduce pain? This one. Chain with maybe chain with hypnosis, or this one also can be like some kind of the limbic system, like something that I think like I also don't know that mechanism for this one. Okay? Okay, cannot change. Okay. What is the next slide? This one? Okay. So whatever you learned just now is endogenous pain control. And then also that non-pharmacological. Pharmacologically, we can suppress pain by giving analgesia, right? Analgesia and also opioid analgesic. Okay, opioid like we have codeine, we have morphine. Okay, so this is the area that this. Okay, here you can see that if let's say like you give NSAID, what is NSAID? Non-steroidal anti-inflammatory drug. Okay, if we give NSAID, then it will inhibit this, we call the cyclooxygenase pathway that will inhibit release of prostaglandin. So prostaglandin is the thing that stimulates pain. They stimulate to the C nerve fiber, right? Pain nerve fiber. Once we give this one, it will inhibit the pathway of the cyclooxygenase pathway. Okay, inhibit prostaglandin release. By that way, pharmacologically, we can inhibit for that. And also that if we give opioid analgesics, then it will inhibit the excitation of transmission to the neuron. Okay, it can inhibit, and also the designing inhibitory pathway. If we give morphine, then it will combine with a lot of morphine receptor we have, right? So they will inhibit to the pain pathway that is synapses at the level of the cerebrocardium. Okay, second order neuron. Okay, so this is a pathway or the mechanism that we can inhibit pain sensation. Okay. Okay. Okay, local anesthesia. Local anesthesia can block the pain by blocking sodium channel, right? By blocking action potential. Action potential that generated at the nerve, right? So this one since beginning that you know about that one. By inhibiting that nerve, this one ionate entry, they cannot degenerate action potential because sodium is important for depolarization. Okay, and then NSAID, okay, already. Already explained, and opioid also already explained. So move to next. Can you check your PowerPoint? Okay. So next is thermoreceptor. Okay, temperature sensation. So we have warm and cold, right? So which nerve fiber carry temperature sensation? C fiber. Okay, C fiber. Okay. If let's say like warm will be C fiber, definitely cold receptor has been okay. If the delta fiber will be cold, okay? Some cold sensation will be transmitted by type C, but cold mainly is delta fiber, okay? Same pathway you can apply for temperature, okay? Okay, so temperature, that's all. So many pain pathway that you must know. Temperature also need to know, but you can apply temperature similar like same theory to the pain. Okay. So next is Brown sequence syndrome. So the Brown sequence syndrome is localized injury. Okay. Let's say like gunshot wound or stab wound, only one side. So it will causes the one side of spinal cord lesion. Okay, in the third row that you can see Brown sequence syndrome, penetrating injury, penetrating trauma. It will causes ipsilateral loss of motor, okay, forget motor later, and vibration sensation, proprioception, ipsilaterally, okay. Ipsilateral loss of vibration and proprioception, meaning that which arsenic thread is defective and not functioning in Brown sequence syndrome. If the patient lost vibration proprioception, then which arsenic thread is defective? D. DCML pathway. Okay. If temperature, pain sensation, anterolateral. If proprioception and vibration, it will lost ipsilaterally. Let's say like step 1 here. Okay. This side, right side. Then vibration proprioception loss will be same side because they cross the cassette at the level of the brainstem, right? But if sensory loss, pain and temperature, loss will be contralaterally because they cross opposite side at the level of spinal cord, right? So Brown sequence syndrome in OB we always ask. If let's say like the people lost pain and temperature sensation because of Brown sequence syndrome, it will be contralateral loss. Okay. If the people lost sensation of vibration proprioception due to Brown sequence syndrome, the sensation loss will be ipsilateral. Just now it's contralateral. I think I only mentioned. Is it? If pain and temperature loss because of Brown sequence syndrome, it will be to the opposite side. Okay? Contralateral. If vibration and proprioception loss because of Brown sequence syndrome, loss will be ipsilateral, same side. Okay? Last slide. So here you can see that it's either step wound or gunshot wound, right? Okay. If the loss of vibration will be same side because this pathway, DCLM pathway, haven't crossed to the opposite side at the level of spinal cord because Brown sequence syndrome is injury of the spinal cord, only one side. Okay, lesion at the spinal cord level, or injury here, okay, wound is here, and then the loss of sensory like pain and temperature will be opposite because they already crossed to the opposite side at the level of spinal cord. Right? Clear? Okay. So these are the things for the lateral, anterior and lateral spinothalamic thread you have to know. Okay. So this is application, apply effects. Okay. So to summarize, somatosensory thread, not only for ophthalmology, also you have the sensory processing start from the stimulus. Okay. So that will be sensed by receptor. We have different type of receptor. That receptor will transform mechanical energy into the forms of action potential. That action potential will be coded by afferent nerve or sensory nerve. That nerve, whatever you learn like DCLM pathway, A delta nerve, and then lateral spinothalamic thread like A delta C nerve, and it is interpreted by central nervous system. Okay. Then you have main somatosensory area. Okay. Receptor like mechanoreceptor, proprio, nociceptor, and thermoreceptor. Whatever you learn more like classification, don't worry about that. But these four you need to know. Okay. Type of four main receptor. Okay. And then according to the pathway, that we have two main pathways. You learn two main pathway. One pathway carry vibration and proprioceptive sensation, that is dorsal medial lemniscus pathway. Another one is anterolateral pathway, carry pain and temperature. Okay, sensation. Okay. And the pain sensation that we can again divide it into the based on the types of pain, severity of pain, sharp pain or slow pain. Okay, sharp pain is carried by neo, okay, and then slow pain by paleo. While slow pain gives rise to the autonomic response or the emotional the response. Because of branches to the reticular area, limbic system, and hypothalamus. Okay. So that's all, that whatever you learn. Okay, so please read carefully and please study for this pain or sensory pathway because it is very important for exam. I hope that you can answer very well in exam. Maybe like it can come out in semester 2 exam or it can be in the final exam, very sure. Okay? So, okay, but when I check the answer, wait. Quiz. Why quiz? Okay, number 5, check number 5 again because just now you haven't learned about neo, spinal thalamus and paleo. A medical student is assessing a stroke patient response to a vibration stimulus. Okay, which of the following sensory pathway is being assessed in this patient? Dorsal column. If let's say like I change the question to response to the temperature. So temperature
and
Hey.
Temperature paleo.
If temperature will be combined answer of C and D, right? If I put temperature, I will not give you C and D. I will give you something like lateral spinal thalamic. Okay? Lateral spinal thalamic. How about the sharp pain?
Sharp pain neo.
Or I will specify like the student is suffering from the stomach pain. She cannot sleep the whole night. Paleo. Okay, paleo spinal thalamic. Okay. Number 6.
Brown sequence
Okay, Brown sequence syndrome. It laterally lost which type of sensation? Proprioception and vibration. Okay, contralaterally lost which type of sensation? Pain, temperature. Okay, what is the correct answer? Proprioception. Okay, proprioception. If no proprioception, then I give vibration also will be correct answer. Okay. Next. Why not changing? Same. I only put 2.
Which of the following sensory model in my system is reflected in patient with spinal thalamic
Okay, spinal thalamic thread injury likely to which of the following sensory modality? Spinal thalamic thread. Spinal thalamic thread. But spinal thalamic thread inclusive of dorsal column, BCLMA pathway, and also anterolateral, right? So is the questions make sense or not? No, right? This one too general because everything is correct, right? Okay, let's say like I will say. Foreign sensory will likely to be affected in patient with anterior spinal thalamic thread injury. Anterior crutage or fine touch? Anterior crutage. anterior crutage, and then fine touch, proprioception, and vibration will be
This year.
DCMLN. Okay, DCMLN.
Aku ingat sekarang.
Number 9. Okay.
Aku punya study ni lah. Dia kata mesti nak
Okay. So anterior spinothalamic tract carry what type of sensation? Anterior.
Uniform interphalangeal.
Anterior carry what type of sensation? Crutage and pressure, the high pressure. Okay. Dorsal column tract,
Everything anesthetic goes.
vibration and proprioception. Lateral spinothalamic tract,
Bukan uniform.
pain and temperature. Lateral pain and temperature. Okay. Spinocerebellar, proprioception but unconscious. Okay, unconscious. This morning you learned that one. Okay. So go back to question that
B.
examining which
Uniform. Frequency.
tuning fork is for vibration test, right? So the pathway will be assessed
DCL.
dorsal column. Okay, dorsal column vibration proprioception. Okay. Then last question.
Satu tengok yang ada ni severe gastric complaint. Kau ni? Gastric. Kau lah. Termination of the spinothalamic.
Okay, cannot sleep because of severe gastric pain. So gastric pain is what type of pain? Shock pain or slow pain? Okay, icky pain, internal organ pain. Which of the following is take best? Okay.
True.
Simon first order neuron, okay, yeah. Fixation and second order neuron. Termination of spinothalamic fiber. So because of reticular, because A and B cannot give any sensation, just very lower level. Haven't reached to the sensation area, right? Not reached to the conscious area. Only that when they reach to the reticular formation area, they cannot sleep because of its activate to the reticular activating system. Okay. For number D, feel pain, but it's not related to the sleeplessness, right? Okay. That's all. Thank you very much. If you have any question, you can ask like this. Okay. I also can ask.